Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. For this breakout session, ECG interpretation is a must-know for all physicians. Let us learn the basics of ECG interpretation with Dr. Maria Blanca A. de Guzman, a fellow of the Philippine College of Cardiology and the Philippine College of Physicians, and an expert in cardiac pacing and devices. She is currently practicing in Bulacan area and is an active consultant in the Valenzuela Crit Care Medical Center and De Los Santos Medical Center. This session will be moderated by Dr. Jason S. Santos, a Level 3 echocardiographer, Fellow of the Philippine Society of Echocardiography, Philippine College of Cardiology, and the Philippine Heart Association and Philippine College of Physicians.
So, a good day to all our attendees for this postgrad. I am Dr. Blanca de Guzman, and I've been tasked this day to discuss with you a very common diagnostic tool that we have available for everyone, and that is the ECG. So I know that some of you may be quite intimidated when we talk about the ECG, but let me try to make it as easy to understand and as less intimidating as I can. So let's start. So an ECG, as we know, is a valuable record of the heart's electrical activity. It basically is the electrical recording that would eventually translate to mechanical events. This important diagnostic tool also aids in the evaluation of very important cardiovascular diseases such as our cardiac arrhythmias, our myocardial ischemia and infarction, even gives us a hint if a particular chamber of the heart is enlarged. We will have to remember that the ECG has been around for quite a long time already. It is one of the most economical diagnostic tools that we have, the most readily available, one of the most easy to do diagnostic tools. So I guess everyone would have to at least have a basic knowledge of how to interpret and to recognize important ECG tracings. So for our lecture, we're going to basically have a very simple and quick review of the anatomy and physiology of cardiac conduction. We will again review the different waveforms of the ECG so that we know how to give the interpretation of a normal sinus rhythm whenever we get the ECG tracing. And finally, we're going to review some of the important cardiac arrhythmias that one must be able to recognize in the clinic and even in the emergency room. So as we know, the beating heart is not mainly a mechanical activity. The movement or the contraction of the heart is affected by an electrically stimulated process. So we know that the cells will have to undergo depolarization to be able to get stimulated electrically, hence causing the mechanical contraction of the heart. And we know that these electrical activities and events of the heart are the ones made recorded by the ECG. So remember that depolarization basically means that the cells or the inside of the cell is made more positive, while repolarization allows us to restore the cell's interior into its original negative charge. So again, let's put in mind that depolarization means that the cells become more positive, while repolarization turns the cell back into its negative charge or resting membrane potential. We know for a fact also that depolarization equals contraction, while repolarization, on the other hand, would mean relaxation. So these are very basic concepts that would aid us later on as we try to go through our lecture in the ECG. So basically, the ECG measures the average action potential of the heart. So basically, it is showing us the mean movement of the action potential along the electrical axis of the heart. So we will have to remember that our ECG nowadays consists of both bipolar and unipolar electrodes. When we talk about bipolar electrode system, it is one where the electrodes present in the system are able to detect the electrical signal and able also to record the difference between the two signals. This comes in very handy later on as we try to interpret the ECG tracing and determine if what we're looking at, the waveforms, I mean, are actually normal or abnormal. Just remember that if the lead that we are looking at basically records or receives an impulse towards the normal electrical axis flow of the heart, then what you see in the ECG are actually positive or upward inflections. Whereas if the lead that we are looking at basically is on the opposite side of the spectrum, meaning it receives flows of electrical impulse that is away from the natural or the normal electrical axis of the heart, then it's going to show us negative waveforms or negative deflections. If it's basically equiphasic or is perpendicular to the axis of the heart or the normal axis of the heart, then as shown in the lower tracing in this slide, what we see are actually equiphasic, meaning they are neither generally positive or overtly negative deflections. Instead, we have an isoelectric or an equiphasic waveform that is seen. So as a review, I think everyone is very much familiar with this slide. The basic anatomy and physiology of cardiac conduction shows us or reminds us that the heart's cells are very special because they do have that particular characteristic, which is automaticity. And basically, these automatic cells of the heart are the ones responsible for the actual development of the electrical activity, electrical conduction, and eventually the actual mechanical movement of the heart. We know for a fact that the sinus node, which is located at the right atrium near the sinus, okay, sorry, I'm having some. Okay, there. The sinus node, which is located at the right atrium, basically is the heart's natural pacemaker and is where the main cardiac impulse come from. It actually beats at around or fires at around 60 to 100 beats per minute at rest, making it predominate over the other cells that would actually have automaticity and forms the cardiac conduction pathway of the heart. Now, once the electrical impulse gets from the sinus node or is fired from the sinus node, it travels now to the AV node, which is located or situated in between the atrial and interventricular septum near the tricuspid valve. So once it receives the electrical impulse from the SA node, it eventually delivers the said impulse to the Purkinje system. Now, the AV node, similar to the sinus node, is also able to deliver or to generate its own impulse. However, unlike the SA node, which fires at around 60 to 100 beats per minute, the atrioventricular node or the AV node actually fires at a much slower rate. And more often than not, in instances when your SA node fails to deliver an actual impulse, your AV node provides what we call the escape rhythm, which would serve as the primary impulse of the heart if in cases of SA node failure or dysfunction. Now, once the electrical impulse is received by the AV node, it goes through the ventricles, through the system of the bundle of His, and later on to the Purkinje His network. So this bundle branches, I mean, and the Purkinje fibers actually allows the electrical impulse to move through the ventricles, allowing or providing contractility later on. Now, if the AV node fires and provides an escape rhythm at the rate of 40 to 60 beats per minute, as mentioned, this entire conduction system has that particular special characteristic, which is automaticity. However, your Purkinje network or Purkinje system fires at an even slower rate, which is around 20 to 40 beats per minute. Now, I hope you remember these magic numbers because later on when we discuss our abnormal or common cardiac arrhythmias, this would come in very handy. Okay, so as mentioned, our ECG, so on the right part of the slide, we see an example of a complete ECG waveform complex, whereas the other picture depicts how the electrical impulse is formed and conducted throughout the system. So as mentioned, the ECG basically records or serves as a recording of the electrical impulse formation and conduction throughout the system. So we know for a fact that the SA node comes from the RA. The SA node found at the RA uh, basically gives the first or the main electrical impulse, which affects atrial depolarization. And basically, this is represented in the ECG by the first upward inflection, which is the P wave. The delay in the AV node, or remember that the electrical impulse comes from the SA node, eventually affecting atrial depolarization and going down to the AV node. So there's a particular time of delay for the electrical impulse to get conducted from the main site to the AV node. So this is basically what your PR segment actually represents. Now, the delay is also, or the isoelectric PR segment before the actual generation of the QRS complex also represents the conduction of the electrical impulse through the bundle branches. Now, ventricular depolarization basically is represented by the QRS complex. We have a plateau phase, which is represented by your ST segment. And finally, the third phase or the phase 3, which is your rapid repolarization, is represented by your T wave. So again, to review, the major waveforms which represent the different electrical activities of the heart in the ECG are your P wave, which represents atrial depolarization, the actual delay from the electrical conduction of the impulse from the SA to the AV node, the QRS complex generation, which represents your ventricular depolarization, and finally your rapid repolarization phase, which is represented by your T wave. Now, it is not only important that we get to know or get familiarized with the major ECG waveforms, we would have to also be reminded of what the actual normal PQRST waveforms would have to look like. Eventually, later on, helping us determine whether we're looking at an actual normal ECG tracing. So, as mentioned, the P wave, which is the first upward inflection of your ECG complex, will have to be looking the same morphology, same size, of course, same direction in the same lead. Whenever you're studying your P wave, you would have to look for your P wave and see if your P waves look the same in your leads 1, 2, AVF, and B1. The moment that there are discrepancies in the P wave, then we'll have to think of a certain problem. Okay. Now, as mentioned, your QRS complex represents your ventricular depolarization. So your first part of your QRS complex is the Q wave, which is basically the first negative deflection after or coming right after your P wave. It may be seen in leads 2, AVF, B5, and B6. And we will not have to be so afraid whenever we get to see Q waves in our ECG, so long as the Q waves will have to be normal, meaning they're not so wide. They shouldn't be less. They should be less than 0.04 second. They shouldn't be too deep or too low when it deflects, and it should only be less than 2 millimeters. And if you can look or take a look at the succeeding R wave of your QRS complex, the Q wave shouldn't be more than 25% of the succeeding R wave. So even if you see Q waves, so long as they don't go beyond these magic numbers, and you don't have to be so afraid and so scared about your Q waves. However, if the Q wave is so wide, if it's too deep, meaning it's more than 2 millimeters, or if it exceeds 25% of its succeeding R wave, especially if you're able to see the Q waves on contiguous leads, meaning leads that once grouped or lumped together actually represents a particular segment or a particular wall of the heart, then you will have to be quite mindful of it, because this might actually be significant or pathologic or abnormal Q waves as we know it. And we know for a fact that presence of Q waves might be indicative of an infarct. Now, the QRS complex, which represents your ventricular depolarization, basically measures zero point zero 0.06 to zero point zero 0.01 seconds, meaning if you're going to take a look at the wideness of your QRS complex, it should be 1.5 to 2.5 small squares only if you're going to look at how wide your QRS is. Here, we are able to see a depiction of how the normal R wave progression in our chest leads or precordial leads should look like. If you're going to take a look at your chest leads from V1 at the septum or the middle part of your patient's chest going laterally, you're able to see that the R wave progression is actually increasing, meaning you have a small R wave in your V1, and as you go laterally, then the R wave becomes taller and taller. So that is what you should observe when you're looking at a normal ECG. Then we have your T wave, which represents your rapid repolarization phase. So normally or usually, if we're going to take a look at the T wave, it should be the same axis or the same direction as its preceding QRS. Now, in certain leads where QRS are positive, then you are also expecting that the T wave should also be in an upward or positive inflection. Normally, the tallness or the amplitude of your QRS should, your T wave should be less than 10 millimeters in our precordial leads. Now, there are certain T wave abnormalities that we would have to be mindful of or are commonly seen in our patients. If you have a very tall or a very big amplitude of your P wave, meaning it's a peak T wave, then you may suspect either we have electrolyte abnormalities, very common among our CKD patients, as in hyperkalemia, especially if you're able to see diffuse T wave peaking. However, if we talk about acute ischemia or acute T waves, then more often than not, the peaking of the T waves are observed again in contiguous leads or leads that, when lumped together, actually represent a particular portion of the heart. Now, on the other hand, if the T wave is seen to be inverted, especially if you're able to see this in contiguous leads, then this may also be indicative of myocardial ischemia. Now, Now, are all T waves always abnormal? Should we always be panicking whenever we see inversion of the T waves? Now, remember, for patients who are 30 years old and above, normally you can see an inverted T wave in lead V1, all right? However, in younger patients, so whenever we go to clinics and we see patients who are less than 30 years old, let us remind ourselves that sometimes we can be presented with ECGs with T wave inversions in leads V1 to V3. More often than not, we call this our juvenile T waves, meaning T wave inversions commonly seen among patients who are a bit younger. Now, that is the reason why we should remind ourselves that we should not only be too focused on looking at the ECG, but also have to take a look at who the patient is in front of us. Okay, so you always go back to the history, you always go and take a look at your patient profile to be able to say and correlate if the abnormalities that you're looking at are pathologic or if they are expected based on the age or epidemiology of the patient. Now again, let's remember our PQRST. P wave represents atrial depolarization, your QRS complex is ventricular depolarization, and your T wave is ventricular repolarization. Now, apart from your P waves and your waveforms, your QRS complex and your T waves, we will have to discuss a little bit also the different basic intervals of the ECG. So again, as mentioned, your ECG tracing shows both amplitude the vertical portion of the or vertical aspect of your waveforms, and the horizontal, or how long it takes for each waveforms to get generated, basically tells us or gives us an idea how long it takes for the electrical impulse to get conducted from one part of the electrical conduction system to the other. So your PR interval, basically, as mentioned a while ago, measures the time from electrical impulse generation at the SA node to the time that it travels to depolarize the atrium, and finally, the time that it reaches the AV node and the conduction towards the Purkinje his. So the PR interval usually is measured on the standard or unipolar leads with the longest PR interval. So the normal PR interval, or the time it takes for the electrical conduction or the electrical impulse to get conducted from the SA to the AV to the other parts of the Purkinje before actual ventricular depolarization, is usually from zero point 0.2 seconds or 3 small squares up to 0 0.20 seconds or 5 small squares. The moment that we get to see that the PR interval is too short, then we might think that it took a very quick time or a quicker time for the electrical impulse to get conducted. So there might be another pathway or a pre-excitation that may be happening. On the other hand, if it takes too long, meaning your PR interval as seen in the tracing below shows that the PR interval is very, very long, then it might be indicative of an AV block or an actual block in the conduction of your electrical impulse. Your QRS duration, as mentioned, should be zero point 0.6 to zero point 0.10 seconds in adults. The QT interval, which is measured from the beginning of your Q wave in your QRS complex to the end of your T, basically represents ventricular repolarization, depolarization, repolarization. So remember that your QT interval, as well as the other intervals, basically varies with the patient's heart rate. So more often than not, if the patient's heart rate is too fast or too slow, then we will have to correct and compute for the corrected QT interval. So the Bizet's formula here presented shows us how to compute for your corrected QT interval. More than zero point 0.45 seconds for men or more than 0.46 seconds for women are indicative of prolonged QT interval. So why is it so important to take a look and actually compute for your QT interval in cases when you have either a bradycardic or a very tachycardic patient? This is the reason why, because certain abnormalities and even predisposing factors to ventricular arrhythmias are hinted by a very short or a prolonged QT interval. So your ST segment, which is the beginning of your ventricular repolarization, is also a very important segment to look at, especially if we're talking about ischemia. So normally, your ST segment should be isoelectric. However, there are certain deviations about 0.5 millimeters depression or up to 1 millimeter inflection from the baseline may still be acceptable. So as mentioned, ST segment deviations are very important, or taking a look if your patient's ST segment is either depressed or elevated is significant clinically because it might be indicative already of your acute infarction or AMI. And in case of ST segment depression, especially this particular characteristic tracings are very significant. So it's definitely more than zero point 0.5 millimeters downward depression for your ischemia. And definitely your tracing for the ST segment elevation, indicative of acute infarct, is more than 1 millimeter. So it may be indicative of these abnormalities. So that's the reason why we'd have to take a look also at our ST segment deviations. Especially, again, we will have to remember that if we talk about infarction, myocardial ischemia, it is not only the characteristic of the ST segment, even the T waves that is important. We will have to take note that these are seen in contiguous leads, meaning leads that represent a particular wall or portion of the heart. So basic elements of your electrocardiogram. So these are the steps on how to conduct your recording. Now, more often than not, we allot these particular steps to our secretaries or to our cardiac technicians. But I guess as physicians or as trainees, it is important we get to know also and familiarize ourselves as to how we do an actual ECG recording. So this is just showing how an actual recording paper for your ECG looks like. As mentioned a while ago, your normal standardization and indications for your ECG tracing has two components. So when we talk about the vertical aspect of your tracing or of your paper, basically that entails or that gives us an idea of how tall or the amplitude of the actual electrical impulse is. When we talk about the horizontal aspect of your ECG paper, that would depict the time or duration by which each of the cardiac events are actually taking place, or how long does the electrical impulse gets generated and conducted throughout the electrical conduction system. So this, I think, is very familiar to everyone. This is an actual ECG tracing and paper or the ECG of one of our patients, a sample. So again, the leads of the ECG, we have 6 lead leads, both augmented and standard. Standard leads meaning the bipolar leads and the unipolar leads or the augmented leads. And we have 6 chest leads. So the limb leads, particularly the bipolar leads as mentioned, is able to take note of the difference between the action potential at 2 points. So your lead one basically receives electrical impulse from the right arm to the left arm. Your lead two from the right arm to the left foot. And your lead three basically determines the difference from your LA or your left arm to your left foot. Your unipolar leads basically are taking a look at electrical impulse at a certain point. So AVR is for the right, AVL is for the left, AVF is basically the foot area or the posterior portion of your patient. So it is quite necessary that we take a look at the hexaxial system because basically this plots the different direction by which the the different limb leads take a look at your heart. So the electrical impulse normally goes from the right of the patient to the left of the patient and from the superior portion of the patient to the inferior portion of the patient. So if we're going to take a look and plot the different leads of our patient, the different limb leads, it basically allows us to take a look at the heart from different angles or different portions. So it's like taking a snapshot of your heart so that we can depict the heart more appropriately. So, for example, if you're going to combine the bipolar leads with the unipolar electrodes, we're able to form the hexaxial system and lumping together, for example, your AVL, which is a unipolar lead with your lead one, basically takes a look at the high lateral portion of your heart. Whereas grouping together your leads AVF, lead 3, and lead 2 takes a look at the inferior or lowermost portion of the heart. So it's, as mentioned, like taking a picture of your heart from different angles so that you'd have an idea of how your heart looks like. Now, your chest leads or your precordial leads is a bit more easy to understand because basically where you put the lead basically gives you an idea of what particular part or portion of the heart it represents. So as seen here, your lead V1 and V2 is situated at a more central portion, more central part of your chest. So basically, it covers for your septum or interoceptal wall. Your V4 and V3 basically represents or depicts the anterior portion of the heart, whereas your lateral precordial leads, namely your V5 and V6, basically represents, or if lumped together, would represent your lateral portion. Okay, so remember the ECG tracing that we had a while ago. So if you're going to put together your 1 AVL and your V5, V6, that those particular leads basically represent the lateral portion of the heart. So it's as if you're taking a look at the lateral portion of the heart. Hence, if you're able to see the ST segment deviations that we were talking about a while ago, or even the T wave inversions that may be indicative of ischemia, as mentioned a while ago, in these contiguous leads or leads that are grouped together to represent the region of the heart, then we would know that most likely these deviations and these changes are actually because of an actual infarct or ischemia. Now, as mentioned, your 2-3 AVF, which is represented by the green portion here, basically represents the inferior portion of the heart, while your leads V1, V2, V3, and V4, represented by the red triangle here, represents your anterior septal area of the heart. So any changes or any T wave inversion, ST segment shiftings that are significant, especially if grouped together in these leads, would be giving more credence to an actual infarct or ischemia rather than a more systemic problem. So normal ECG, basically, for us to say that the ECG is normal, apart from looking and being familiar with how the actual waveforms should look like and what do they represent, you will have to take a look at these criteria. So similar to beauty pageants, you have criteria for ECG, for ECG interpretation. So let's go through this very quickly. When we talk about regularity, is it regular or irregular? So basically, we know that each QRS complex, PQRST complex, represents an actual cardiac cycle. So if the R to R interval or the P to P interval basically measures the same, then we can say that it's regular, right? However, we can allow for some variability, up to 10% variability, or not more than three small squares if in a particular tracing, we get to see that the R to R or the P to P intervals aren't actually of equal distances. So you take a look at the shortest one and compare it with the apparently seemingly longish one. If it doesn't exceed more than three small squares in difference or not more than 10% variability, then we can still say that relatively it's still regular. However, if the shortest distance between an R to R complex or a P to P um, wave is more than three small squares, then we may say that it's already irregular. So that is what we're talking about. There you go. So this particular example, we can see that it's equidistant, the QRS complexes, and if we even compare the P waves, so we can say that this particular tracing has a regular rhythm. Whereas, if you're going to take a look at this sample, we have very irregular rhythm because the QRS complexes aren't actually equidistant to one another. And if you're going to take a look at the shortest P to P or R to R distance and compare it with the longest one, definitely it's going to be more than three small squares or more than 10% variability. So this is an irregular heartbeat. Now, the rate, how fast should the beat of the heart be? So, remember, I always tell this to our juniors that it is fun to count heartbeats. The moment that you don't or unable to count heartbeat, then that's the time that we get to be panicky, right? So, how do we get the normal or how do we know if the patient actually has a normal heartbeat? So we usually have two ways of determining it if we are dealing with a regular rhythm. So if you're very, very exact, then what you can do is divide the number of small squares from 1, 5. So for example, in a tracing like this, okay, there are 23 small squares in between two QRS complexes. So 1, 5 divided by 23 is actually 65 beats per minute. Okay. Now, there is actually a fast method, especially if you're in a hurry, you're in the ER, you're in the ward, and you're about to have your rounds and just have a quick look see at your ECG. So what you usually do is you get to find an ECG signal that falls right smack a heavy line and then start counting the big squares in this particular interval. So 300, 150, 100, 70, 60, and 50, 75, 60, and 50. Now, for this particular example, we can say that the next signal after the signal that actually falls into the heavy line is between 60 to 75 beats per minute. So we can say roughly that the rate of the patient is around or between 60 to 70 beats, 75 beats per minute. So you just have to memorize this sequence if you're in a hurry. So again, fast method, we get to see here a QRS complex that falls right smack the the heavy line in the ECG tracing paper, 300, 150, 100. So the exact rate, if you're going to recall, our first example is 65, but if you're going to do the fast method, then roughly you can say that it's between 60 to 75 beats per minute. If you have an irregular rhythm, then you can still determine the rate of your patient. So how do we do that? We get to see an ECG strip, make sure that it's 6 seconds. You count the number of QRS complex within the 6 second strip and multiply it by a factor of 10. You get your rate. So example, this is a 6 second strip. You can see QRS complexes that are not actually equidistant from one another. So we know that this is irregular rhythm. So we just have to count the number of QRS complex present. So there are 12 and multiply it by 10. There you go. You have the actual rate of your patient. So this is another example. This is a 6 second strip. You actually have seven unevenly spaced QRS complexes present. So 7 multiplied by 10 gives you 70. So for this irregular rhythm or irregular tracing, the beat of the heart or the heart actually beats at 70 beats per minute. Now, the next criteria for you to say that it's a normal ECG is it a sinus rhythm or is the rhythm actually coming from the normal pacemaker of the heart? So we know for a fact that it is of sinus origin if the impulse actually um, generates a P wave which is followed by normal looking QRX complexes. And more often than not is conducted at 60 beats to 100 beats per minute. So in a normal sinus rhythm tracing, the P wave, or there is always the presence of the P wave, which represents your atrial depolarization and normal impulse generation, it should always be followed by a QRS complex at a regular rate. So that means that your electrical impulse coming from the SA node actually got conducted throughout the entire electrical conduction pathway. So again, look at the P waves or look for your P waves. Make sure that the rate is regular. Make sure that the rate is 60 to 100 beats per minute. Look at your waveforms. See if they have the correct contour and shape. See your intervals so that you'd be able to determine and say that you have actual normal sinus rhythm. So this has been discussed a while ago. So our PR interval, QRS duration, and QT intervals basically are measures of how quickly electrical conduction or electrical impulse conduction occurs throughout the conduction system. So as a review, your PR interval should only be 0.12 to 0.20 seconds. Your QRS duration, which is your actual ventricular depolarization or contraction of your ventricle, should be zero point 0.6 to zero point 0.10 seconds only. And your QT interval, corrected at that using the Bazette's formula, should be less than 0.45 seconds in men and less than 0.46 in women. Finally, your QRS axis. Basically, when we talk about the axis of the heart, it is the indicator of what is the general direction of the wave of depolarization or the actual travel of impulse and flow from the atrium through the ventricles, effecting actual mechanical contraction of the heart. We know for a fact that it starts from the right hand corner and goes to the bottom left hand corner. So that's the normal general axis of the heart. So this hexaxial system, as mentioned, allows us to plot the different limb leads at different angles from where they get to see the electrical impulse conduction flow. And as I mentioned a while ago, lumping together, these limb leads allows us to take a picture of the heart from different angles or different portions. So for quick access determination, because this can be quite taxing if you're going to plot and plot all the different leads, right? So you just have to take a look at your lead one, see if since lead one basically measures your or takes a look at the electrical flow from your left arm to from your right arm to your left arm, then we know for a fact that your lead one should be upright. Same is true with your AVF, since it takes a look at the electrical impulse at the foot or at the inferior portion of the patient. So if this will be our plot, we will be able to determine, therefore, that the normal axis of, or roughly say that your patient's electrical tracing or your ECG has normal axis if you get to see that the lead 1 and lead AVF has both upward inflection, meaning it follows the correct electrical impulse conduction or general direction or axis of your electrical impulse conduction. If the lead one is negatively deflected and your AVAF is actually upright, then we can say that you have right axis deviation. On the other hand, if your lead one is positive and your AVF is negative, then you have left axis deviation. Finally, if both your AVF and your lead 1 is negative, then you have extreme right axis deviation. So again, this is a depiction of a quick determination or a quick step to know if your patient's ECG or the ECG you're taking a look at has normal axis or abnormal axis. So you just have to take a look at your lead 1 and AVF. Know that the normal is lead 1 and AVF should have positive inflection. So, is it regular or irregular? Definitely, this is regular. Is it fast or slow or normal? Definitely, it's normal rate. Is it sinus? Is the rhythm coming from the sinus node? We can say that yes, because we have here P waves followed by normal looking Q or ST complexes all the time. And we can say also that the basic ECG intervals are normal. So going through this list quickly and getting familiar with how each waveform should look like allows you to know if you have sinus rhythm. Finally, after taking a look at what is normal, we go now to the different rhythm abnormalities. So there are other abnormalities that we can take a look at the ECG, but for this particular lecture, then we just have to focus at rhythm abnormalities. So let's start. So for purposes of discussion, I decided to group them together according to whether we're looking at benign rhythms, we're looking at slow or bradycardic rhythms, tachycardic or very fast rhythms, and finally, rhythms that would cause even the doctor to palpitate because they are fatal arrhythmias. So let's begin with benign rhythms. So when we talk about benign rhythms, these are rhythms that wouldn't necessarily mean that the patient is having an abnormality or an actual cardiac disease. It may actually be a physiologic response or it may be due to another problem. So that would give us ample time to take a look at the patient and actually monitor and work up the patient. So for example, when we talk about sinus bradycardia, everything in the ECG of the patient is normal, apart from the fact that the patient's rhythm is slow. So if it's less than 60 beats per minute, then all the rest of the criteria that we discussed a while ago is normal, then we're dealing with sinus bradycardia. On the other hand, if it's just the fastness of the rate that is the problem, meaning it's more than 100 beats per minute, but all the rest of your criteria got ticked as normal, then we're dealing with sinus tachycardia. Okay. So a while ago, we discussed that one of the basic criteria for you to say that the patient's rhythm is sinus is the regularity. So as mentioned a while ago, if the patient's cycle varies for more than 10%, or if the shortest cycle exceeds more than 3 small squares or more than 0.12 seconds when compared to the longest cycle in a particular ECG tracing. However, all the rest is normal. The patient has a P wave followed by normal looking QRS. The rate of the patient's heart is still at 60 to 100 beats per minute upon computing or taking a look at the rate using the irregular rhythm technique that we had a while ago. then what we have is sinus arrhythmia. Okay. Now, as mentioned during the first part of the lecture, the entire electrical conduction system has that very particular and important special characteristic of automaticity. So there are certain representations of this foci in the atrium of the patient that may generate another beat other than the sinus node. So this is what the premature atrial complexes would normally represent. So they are, as the name implies, they are prematurely occurring compared to the normal actual beat of the heart. If we're going to take a look at our example, the P wave of this PAC is slightly different in configuration. It's a bit narrowish compared to our normal looking P waves, and the QRS is also narrow. On the other hand, your ventricles or the ventricular, the Purkinje system in the ventricles may also fire and give out uh, another electrical impulse other than the electrical impulse actually coming from the SA node that got conducted throughout the entire system. So this is what the premature ventricular complexes would actually represent. So usually your PVCs, as seen here, are bizarre looking complexes. They're usually wide. More often than not, the QRS complex is in an opposite deflection as your T wave. So remember a while ago when we were discussing the normal morphology and how a normal T wave or QRS would look like, we said that the T wave usually follows the general direction of the preceding QRS. It is the complete opposite, or it is the opposite of our PVC. So when the foci where a particular premature beat is coming from the ventricle, then the QRS complex is in an opposite deflection as the T wave. Also, we notice here that before the actual rhythm restarts again, the normal rhythm restarts, there is a compensatory pause that follows your PVC. So that's characteristic findings in the ECG when we talk about your PVCs. Now we go to the bradycardia. So as mentioned, bradycardia means you have a slow heart rate. So we said that sinus bradycardia, everything else is normal apart from the fact that your patient has low heart rate. Now, a sinus pause is when your sinus node does not fire. So it is a particular time when you don't see any P wave and you don't have any QRS in a particular segment of your ECG. So here, normally you have P waves followed by normal looking QRS. Now, there are certain points or at certain patients, the SA node arrests or does not fire at all. Hence, we don't develop a P wave, or we don't also generate any QRS complex. So simply it pauses. So it is also notable that the interval between the previous beat and the next beat following the pause is less than twice the normal interval. So this is characteristic of sinus pauses. Now we talk about bradycardia, or heart rates that are quite slow. Sometimes we attribute it because the actual conduction from one point of the conduction system gets blocked or is actually delayed, causing slower impulse generation and conduction throughout the electrical system. So when we talk about the first degree AV block, here the SA node fires, the impulse gets conducted, and the pathway has regular rhythm. The only problem, if we are talking about a first degree AV block, is that it took a while for that electrical impulse generated in the SA node to actually reach and get conducted through the AV node and to the Purkinje system before the actual ventricular contraction. So if you're going to think about it, when we talk about first degree AV block, it's a misnomer because there is no actual block. The impulse did get conducted. It's just that it took a while. So in the actual ECG, what we see as characteristic of first degree AV block, so this is basically a traditional label already, is we have prolongation of your PR interval. So as mentioned a while ago in the lecture, the normal PR interval is from 0.12 to 0.20 seconds. So if the PR interval that you measure is more than 0.20 seconds, so in this particular example, we have 0.28 seconds, then we have first degree AV block or prolonged PR interval. So when we talk about second degree AV block, here the P wave is present. There is a PR segment present as well. However, we are able to appreciate what we call a drop beat, meaning intermittent P waves are not actually followed by a QRS complex. So when we talk about second degree AV block, the actual P wave, which represents generation and conduct atrial depolarization, doesn't get through your ventricle to form an actual QRS complex. So here we have an actual block. So there are two types of second degree AV block. We have Mobitz 1 or the Wenke back, and we have the Mobitz 2. So Mobitz 1 is there is only one single P wave that is blocked, and it is noticed that the PR interval um, preceding the actual drop beat or block is progressively lengthening. So another characteristic of the Wenke back phenomenon is that the PR interval, the longest PR interval, which is actually more often than not before the actual drop beat, um, is considered the one that is going to be the most prolonged. Whereas the shortest PR interval is usually associated with the first conducted beat right after your drop beat. So group beating basically means that if you eyeball or if you get to see the ECG tracing of patients with second degree AV block, it would appear as if certain groups of QRS complexes are lumped together because they're interspaced between the actual drop beat or spaces produced by the drop beat. So this is what we call cropped or group beating. Also, when we talk about second degree AV block type 1 or the Wenke back, the rhythm is usually irregular because of the progressive lengthening of your QRS complexes, your PR interval before the actual pause or the actual drop beat. And we get to see that the QRS complexes more often than not are narrow. On the other hand, if we talk about Mobitz type 2, again, there's only one single P wave that is blocked. And if you get to see the PR interval before or preceding the actual drop beat, they're not progressively lengthening. Okay. QRS complexes are also more often than not wide because the PR interval preceding the actual drop beat aren't lengthening or progressively lengthening. The R intervals more often than not are constant, and the actual pulse rate of the patient, if checked, is appearing to be regular. So when we talk about high-grade AV blocks, then there are two or more. So remember, second-degree AV block, there's actual drop beat, but it's just one single atrial depolarization, atrial sinus node impulse conduction that is not conducted through the ventricles. It's a different story altogether if we're talking about an advanced or high-grade AV block. Here, in this example, we have several P waves that are not followed at all by your QRS complex. So in this case, what we actually see here is long pauses signified by ventricular standstill. So your atrium fires, your SA node generates and generates your electrical impulse. It's able to generate an actual P wave in your in your ECG, but it doesn't get through and actually cause ventricular depolarization and actual mechanical contraction of your ventricle. So this particular tracing requires immediate attention and immediate referral to a specialist. Similarly, your third degree AV block or your complete heart block is characterized by atrioventricular dissociation. So here in this example, we get to see that the atrial and ventricular rhythms are independent of each other. So the atrium fires, usually it fires at a much faster rate. We know that for a fact. But your ventricle also fires on its own at a much slower rate. So the P waves, as seen in this particular ECG tracing, is not at all related to your QRS complex. So there is actual atrioventricular dissociation. So similar to your high-grade AV block, your second-degree AV block, Mobitz type 2, your third-degree AV block requires immediate attention and immediate referral to a heart rhythm specialist because these particular heart blocks may predispose your patients to fatal occurrences and events like sudden cardiac death or actual standstill. So when we talk about escape rhythm, so in cases when your patient's sinus node does not do its part or does not do its job, then we know for a fact that the AV node and the entire Purkinje system is capable of firing on its own. It's just that it's not as fast, right? So your junctional rhythm basically is a rhythm that comes from your AV node and bundle of His and AV node system. So it fires at 40 to 60 beats per minute. It's basically regular. So since it doesn't come from the atrium or the SA node, we are not able to appreciate normal looking P wave. Sometimes it's even absent. If in case your P wave is present, then we often see what we call your abnormal P waves or your retrograde P waves, your P waves that are already buried in your QRS ends, or your inverted P waves. Not similar to your normal looking P waves, simply because junctional rhythm isn't actually a rhythm that's coming from your SA node. So it basically comes from your AV node. So another characteristic of junctional rhythm, apart from the absence of your P waves or presence of abnormal P wave, abnormal looking P waves, is that it's regular, it's narrow since it's still above it's still suprahishan, and um, it is regular. Now, your idioventricular rhythm basically comes from, or an escape rhythm that comes from a ventricular foci. So as mentioned a while ago, if you're going to see, remember that the PVC or a ventricular beat basically is bizarre looking with the T wave in the opposite direction. So a rhythm or an idioventricular rhythm basically has PVCs comprising the rhythm. So the rate is at 20 to 40 beats per minute. It's regularly occurring. Again, no P waves are appreciated in the ECG since it doesn't come from the SA node and it's not generated in the atrium. And since the rhythm is coming from a ventricular origin or from a ventricular foci, the QRS appears to be wide, bizarre looking, and in the opposite direction of the QRS. So this can be easily downloaded from the American Heart Association. So whenever we get to see or meet bradycardic patients in our clinics or at the ER, this is a very simple algorithm that we can use to be able to treat and give immediate attention to our patients with bradycardia. So what is very important, probably a take home for patients with bradycardia, is apart from knowing how to interpret and catch that the patient has this particular bradycardic rhythm, please always go back to your patient. If you're going to see at the center of the algorithm, what is important is the clinical status or the actual um, hemodynamic stability of your patient, because that's going to determine whether you're going to be aggressive in your management or you're just simply going to monitor, observe, and look for the reason why your patient is bradycardic in the first place. So it is important, yes, that you know how to identify bradycardic rhythms, but you would always have to go back and take a look at your patient if the patient has this red flag signs due to your bradyarrhythmia. Now, we talk about tachycardia. So, if bradycardia means slow heart rate, tachycardia basically means fast heart rate. So, for easier understanding and to facilitate our discussion, I think it would be better to group together or group our fast rhythm abnormalities as to narrow QRS complex tachycardias and wide QRS complex tachycardias. Basically, when we talk about narrow QRS complex tachycardias, it's supraventricular in origin. So remember, if it's not from the ventricle, the QRS complex appears narrow. However, if it's ventricular in origin, more often than not, it is wide QRS complex. Okay. So let's talk about supraventricular or your narrow QRS complex tachycardia. So this is something that wouldn't have to worry us because it's just sinus tachycardia, which we've discussed earlier. Now, remember a while ago when we were discussing the P waves, we said that the P wave in a particular lead should all look the same and they should have the same morphology and same size. Now, in this particular abnormality called the multifocal atrial tachycardia or MAT, The electrical impulse actually originates irregularly and rapidly from different points at the atrium other than the sinus nodes. So when you take a look at the ECG of the patient, the P waves actually do not look the same. Here in this particular tracing, the P wave has three morphologies or three shapes. They look different from one another. And because of that, the QRS complexes following the P waves are also irregularly occurring. So this is an irregular rhythm with varying P waves, varying PR intervals, of course, and the ventricular rate or the generated QRS complexes are also more than 100 beats per minute. So that's why it's very important that we get to discuss first what is normal. Now, when we talk about supraventricular tachycardia, this is characterized by narrow QRS complexes, sudden in onset, also sudden in termination. This is very important. If a while ago we had irregular P waves, irregular rhythm, here we have no P waves. The P waves are not anymore discernible because it's already buried within the QRS because of the very fast heart rate. And SVT characteristically is regular in rhythm. So basically, when we talk about SVT, it's mainly caused by a re-entry circuit around the AV node tissue, or it may involve a normal AV node and an accessory pathway that's causing your heart to beat very, very fast. Okay, your atrial fibrillation is also a common tachyarrhythmia that we see in our clinics. Here, we have irregular rhythm. So more often than not, if we get to recall our physical exam lectures before, whenever we talk about irregular rhythm, often we associate it with atrial fibrillation, meaning the R to R interval of the patient's ECG is not equidistant from one another. We do not actually see an actual P wave. It's very difficult to decipher if there is indeed a P wave preceding the QRS complex or not. Instead, what we see here are multiple reentrant wavelets represented by your coarse or your finer atrial fibrillatory waves. So your atrial fibrillation basically the rate of the patient depends on the response of the ventricle. So if the response of the ventricle, despite the atrial fibrillation or the poorly firing atrium, is within 60 to 100 beats per minute, then this is what we call an average or controlled ventricular response, or AF with average or controlled ventricular response. If the ventricle fires at a much faster pace, then what we have or what we're dealing with is atrial fibrillation with rapid ventricular response. If it's less than 60 beats per minute, it's atrial fibrillation. So your patient's atrium is still in fibrillation. And in response to that, the ventricle fires at a slow rate. So that's what it means basically. Okay, now atrial flutter is something that we will never forget because of the characteristic sawtooth flutter waves. This is what we've been taught before. And more often than not, it is caused by a re-entry around the actual right atrium of the patient. So again, this may be regular depending on the number of atrial flutter, depending on the flutter waves preceding your QRS complex, or it may also be irregular because of the variable AV conduction. So again, to make us remember better your atrial flutter, just remember that it looks like your sawtooth flutter waves. Okay. Now, your ventricular or YQRS complex tachycardia. So we've already mentioned the PVC. It's actually a benign tracing or benign finding in the ECG. Basically shows us that one foci from the ventricle is actually firing and gets manifested ECG tracing. Now, if there are two ventricular contractions occurring consecutively, then this is what we call ventricular contraction in couplets. If it's every other beat, then it's in bigeminy. If it's every third beat, then it's trigeminy. Every fourth beat, and then it's PVCs in quadrigeminy. Okay. Now, remember that sometimes it is not only one electrical impulse coming from one foci in the ventricle that may manifest or may be seen in your ECG tracing. Sometimes there are certain PVCs that don't look the same. They may be of different polarities, different shape altogether, meaning, or it gives us an impression that there are actually more than one foci from the ventricle that's actually giving off this electrical impulse. So this is what we call polymorphic or multifocal premature ventricular contractions. So now this is very important to recognize. So certain PVCs actually show this particular R on T phenomenon. So this is when a PVC, as seen in the encircled portion, occurs at the T wave of the preceding. So it overlaps with the T wave of the preceding sinus beat. Now, why is this considered one of the most dangerous PVCs? Because more often than not, the R on T phenomenon or an actual PVC on top of a Q or an R of the succeeding or the preceding sinus beat may lead to the development of fatal ventricular tachyarrhythmias like um, an actual VTAC. So VTAC naman is if there are three PVCs occurring consecutively. So remember, two PVCs together is a couplet. Now, if you have at least three PVCs, bizarre wide looking QRS complex occurring in succession, no P wave since it's a ventricular origin, then what we have is ventricular tachycardia. Now, there are different types of ventricular tachycardia. When we talk about non-sustained, so at least three PVCs occurring in succession, but it doesn't last for more than 30 seconds. Now, if the PVCs occurring in succession last for more than 30 seconds, so your patient is hooked to a cardiac monitor, for example, you're doing your ECG, and you see nothing but PVCs occurring together in succession for more than 30 seconds already, then that's what you call a sustained PVC, sustained ventricular tachycardia. Monomorphic, as what the name implied a while ago, is if they look the same, right? Meaning they come from a single ventricular foci. Polymorphic or multifocal ventricular tachycardia is when the PVCs, as seen in this example, do not look the same at all. Meaning, different foci from the ventricles are actually firing and generating its own electrical impulse. Now, your torsodic is PVCs occurring in succession in what appears to be a twisting fashion. Again, it's a dangerous fatal arrhythmia that we would have to be on the lookout for. Similar to our bradycardia, we also have, we can easily download this from the latest guidelines from the AHA. So this is a simple algorithm as to how we can better manage a patient whom we seem to be having or who seems to be having a tachycardia. Okay, so again, similar to a bradycardic patient, make sure that you do not only know how to interpret and identify the ECG, make sure that you are able to see and assess your patient properly so as to guide you as to what particular disease or rhythm management you will give your patient. So as you can see in your tachycardia algorithm, depending on the hemodynamic status of your patient. You can either do an electrical therapy, which is synchronized cardioversion if your patient has tachycardia but is not presenting with good hemodynamics, meaning the patient is hypotensive, below 90/60, with altered mental status, signs of shock already, then what you would have to do is already administer synchronized cardioversion. However, if your patient, despite having very quick heart rate, still presents with good hemodynamics, then we may try to look into giving antiarrhythmic infusions and medication. So again, we cannot overemphasize the fact that it's not the tracing that we're trying to treat, but the actual patient themselves. Finally, we talk about our fatal arrhythmias. So this is very, very important, especially for those who are manning the emergency room and the wards. So asystole basically is us not discerning any waveform. So flatline on cardiac monitor or ECG tracing. So more often than not, we assume that the patient is in cardiac arrest. But before we do that, we would have to run a certain protocol, right? And this should be done in less than 10 seconds. We will have to make sure first that is the machine, if the machine is on, if the ECG is actually connected properly, and if the leads are attached properly. Because sometimes you get overexcited, we get to see a flat line. Of course, you don't immediately go and jump on the patient, start pumping, right? And start doing your CPR. You will have to do this check or routine check. Now, if all of these things are present, meaning the machine is on, everything's connected properly, then the patient is in asystole, please do CPR. Okay, so I guess that would be on another lecture. Okay, now when we talk about pulseless electrical activity, When you take a look at your patient, there is no effective hemodynamics, represented by no BP, no heart rate. However, upon hooking your patient to a cardiac monitor or doing your ECG, there's electrical activity detected. More often than not, for pulses electrical activity, what we detect are your escape rhythms. Because the SA node fails so miserably, the AV node or your atrioventricular rhythm supersedes. But still, it is not enough to actually cause actual mechanical contraction and good effective hemodynamics. So if this is the case, no BP, no heart rate, electrical activity seen on your monitor or the ECG, please still do CPR because your patient is still in cardiac arrest. All right. Now, when we talk about ventricular fibrillation, of course, your patient is in cardiac arrest. Here, you are not able to appreciate any true P wave, no true QRS. Basically, what we see in the ECG are just scores or fine chaotic undulations. Your patient has indeterminate rate. Now, if the patient arrests with this particular rhythm in the hospital, then by all means defibrillate. But you're in a public place. Okay, more often than not, it's still the most common cause of sudden cardiac death, ventricular fibrillation. Then, until your EMS comes in or your advanced life support team comes in, all you can do to prevent your patient from deteriorating from ventricular fibrillation to actual flatline is do your hands-only CPR. Perform your CPR. If you have on hand, for example, you're in an airport or mall where you have AEDs available, then by all means use the AED, find someone who knows how to actually use it, and defibrillate the patient. But if you're in a far-flung area, you have sudden cardiac death, remember that the most common still is ventricular fibrillation causing sudden cardiac death. Then both of your hands doing hands-only CPR could potentially save your patient until advanced help comes along. Now, if you have ventricular tachycardia, but the patient has no BP, no heart rate, then your patient has what we call pulseless ventricular tachycardia. Again, similar to the first three tracings that we discussed already, the patient will be or is in cardiac arrest. So you will have to defibrillate. So thinking about it, when we talk about asystole, when we talk about pulseless electrical activity, then you will have to do your CPR. The only two tracings or two rhythms that you will have to do your defibrillation is your ventricular fibrillation and your pulseless VTAC. Because this, based on studies, will definitely increase survival and increase the success of attempted resuscitation for your patient. So if by all means you have a nearby defibrillator and you get to see and attend to a patient with pulses VTAC or VFib, by all means do your defibrillation. Okay, so again, we have here from the AHA latest guidelines, your algorithm for your adult cardiac arrest patients. This is another depiction of your cardiac arrest circular algorithm. So the different shocks or electrical energy therapy, even the drugs that you would have to use. So you can easily download this and go through them one by one. Finally, in patients who have very, very slow heartbeat, in patients with very, very long pauses, sometimes it's necessary to give them some help, give them some aid in the form of your permanent pacemakers. So instead of the actual SA node generating the electrical impulse, these patients with severely diseased SA nodes with severe and very advanced blocks will necessitate the help of these extraneous therapies. So our pacemaker here, as shown in this picture, has a pulse generator or battery with leads attached to it going to your RA and RV to effect proper synchronized contractility. So in the ECG, you know that it's pacemaker rhythm because you have the presence of your pacemaker blips or spikes followed by your wide QRS complex. So I guess, yeah, you'd be able to figure out now Why it's white? Because basically your lead, as seen here, primarily your main lead, which is your RV lead, is seen in the ventricle. So we know for a fact that if it's ventricular in origin, then your, remember the foci coming from the ventricle, then your QRS complex in the ECG would appear wide, bizarre looking, with QRS complex on the opposite direction of your T wave. So it's as if you're looking at multiple PVCs, but actually they're not PVCs. They are impulse generated by your pacemaker lead. Right? So here's another example. So probably you can see here the tiny spikes or tines of pacemaker blips, followed by a good capture or a good actual conduction of the electrical impulse through course through your ventricle. So here we have pacemaker rhythm with good sensing and good capture. So the ventricle is able to contract, generating your PVC looking QRS complexes right after your pacemaker blip. So the pacemaker blip signifies that there's an impulse coming from the pulse gen traveling towards your lead that is attached to your ventricle. Okay. So I hope that, I know that this lecture has been quite lengthy, but as I was telling my residents, usually we give normal and abnormal ECG lectures in a separate session. But anyway, I hope that you've learned a lot, and I hope that you'll be able to use this in your practice and once you're manning the wards, the ER, and your clinics. So thank you very much. God bless everyone and Happy New Year.
You may now proceed to our Sunset Symposia. Please go to www.tiktok2021.com and click on the room you would like to join.